Okay. Hi, I'm Olivia Research, and this year I'm studying pediatric hematology and oncology. I'm a second-year ISM student, and I'm a senior at Frisco. Imagine taking your son or daughter to the doctor, assuming that they had a stomach bug. After a couple tests, you realize that they have cancer. This is how it happens for a lot of kids because the symptoms of cancer are so similar to that of like the flu, and so they the parents misdiagnose it as they just have a stomach bug, and then they end up having cancer. And stories like these are kind of one of the reasons I wanted to get into pediatric hematology and oncology, because I wanted to put more awareness out there, especially for like the symptoms and signs of cancer, and also researching for cures. It's okay. So I chose to be an ISM because I wanted to get connections into the medical field, because I wanted to go to medical school and I want to have like good recommendations. And medical school is like, you have to know you want to go before you like invest your time and your money in it. And so I got the experience through ISM last year to confirm that I wanted to go to medical school for pediatric hematology and oncology. And throughout last year and hopefully this year, I'm going to get more education on the topic. So my quote is, "When you can't change the direction of the wind, adjust your sails." And I think this applies to kids with pediatric cancer because you can't change the fact that you have cancer. Like, you've been diagnosed and you can't help it. So they can adjust their attitude and their outlook and their perspective on the rest of their life about having cancer, and they can see it as, they can like not see it as such a negative, but be more positive about it and find the good in life still. But it also applies to me in my ISM journey because not everything's going to go my way through ISM, and especially last year I got no for my first mentor, and so I just had to realize that maybe he wasn't the right mentor for me and pick a new one, and I'm glad I picked the one I did because I've gotten a lot of good experiences. So last year I studied the same topic with the same mentor, and we started a clinical trial over late effects of fatigue, late effects, specifically fatigue. And the reason I chose to study fatigue is because it's like really poorly studied amongst like the late effects of cancer. I had 6 interviews and they're all really successful, but I'm just going to recap on the 3 most important ones. So one of the interviews I did was with Dr. Patrick Levy, and he talked about the frustration of not being able to cure patients, but like using one treatment for a patient with ALL and using that same treatment for another patient with ALL, and it didn't work. And like he talked about like how he wanted to find one that would work for every patient who had ALL. Like, you know, if you have flu, you get Tamiflu, and it works for everyone. And so he wanted to do something kind of like that. And then he talked about that when he went to talk to his families, like when they came in for a visit, he would like immerse himself in their life, because he said that was like the only way that they would feel like comfortable with you and really explain how they feel so that you could help them feel better. And then he just went over the basics of like how cancer is treated with 3 different things: radiation, chemotherapy, or surgery, and that you don't use each one for each cancer. And then he talked about clinical trials and how they help the doctors like find new ways to help cure or treat the cancer. And that's like, it's really important, and it's another reason like my mentor talked about like doing a clinical trial, because no one's studying fatigue, or like no one studies like something else, but if you never study it, then it can never get better, and it helps with like progression of treatment. My next one was Dr. Andrew Coe, and he introduced me to like a whole new side of pediatric hematology and oncology. I really, like, when I thought of it, I was thinking like, I'm going to be in the clinic, I'm going to be talking to my patients, but he does lab, so he's the one that like works with like, when I went in, I actually got to go to the lab and I got to see like his little rats and, you know, things that he did stuff with, and like the petri dishes and all that stuff, and it was really cool. And it like, I love to learn more and actually like have hands-on like research and stuff, and so I thought that was really cool. And it kind of, I was like, I don't know, do I really want to do clinic, or do I want to do like the lab where I can research? But I found out that like, obviously through my mentor that I picked, like even in the clinic, you still do research because we are doing a clinical trial and he's not in lab, he's just in clinic. So you still get to further your knowledge, and if you're in the clinic, you have to further your knowledge to take the boards every 7 years. And he talked about that kids are more resilient because they have less wear on their organs, like they haven't been smoking or drinking their whole life, so they're like fully functioning and they can help fight off the cancer and sustain like the treatment. And he asked me to ask myself what motivates you, and I actually thought about that after my interview with him. He was like, does your intellectual desire or your emotions drive you more? And if it's intellectual, then lab would be better because you're not really with the patients, you're just doing intellectual stuff, knowledge, research. But if it's emotion, then be with the patients and like be there to help them. And I already talked about this, but I was like kind of iffy on which one I wanted to do, but I decided to do clinic, and it was really good. He also said that you need to be focused and stubborn because you're going to have so many patients that you need to, like, when you go into each room, you need to be only focused on them and with what's going on with them. And then you need to be stubborn because you need to, if you have an idea, like, to treat them with something different than what you're treating them with, you need to be able to be like, no, I think this is going to work. Because if you just let people walk all over you and be like, okay, I guess it's not going to work, and then someone else tries it and it does work, that could have been you, and like you could have helped them. So that was his advice. This is my mentor. That's not a good picture of him. But he specializes in bone marrow transplants. And so, and he talked about the high survival rate of 70% survive and 30% die. But he said it's high because he also talked about like how kids are resilient and it helps them with their treatment. And then he studies immunology as well because chemo like destroys their immune system and they become so weak and like they can't fight off anything, and like sometimes you have to like isolate them from everyone else, and they have to wear those masks because if they got flu, like they could die just from flu or a cold or something. And so you have to be like really careful. And he said that his immunology background really helps him like understand how to deal with his kid's lack of immune system. And like at the hospital where he works, when you go to the inpatient side, like you have to go through this like room, and then like both the doors close, and then it makes this really weird sound, and then you open and go back through the other door. So I think it's like getting like the germs out or something. But yeah, they're in like really safe area. So the research I did was I researched just like the effects of chemotherapy in general. And I learned about how it's not localized, like it doesn't just go to where you have cancer, it goes everywhere, so it kills the good cells and the bad cells. And when it kills the good ones, like that's what causes you to have like problems like nausea and fatigue and things like that. And then I learned about the physical and emotional effects of cancer and like how some of the patients like become depressed and like they don't really want to do anything else, like they just lay in their room and they don't get out of bed, and they're just like physically and mentally like they can't cope with it. And so like they have like social workers come in and like psychologists to help them cope with those kinds of things. And then something that I learned that I had no idea was I assumed that like if you had leukemia and you went into remission that you would have leukemia again, but it's not true. Like you could have, like this is common that after Hodgkin's lymphoma, when you go into remission you get leukemia. And so I thought that was interesting. Another thing I learned about was chronic GVHD, which is graft versus host disease. And when I first went, they talked a lot about it, and I had no idea what it was, and they tried to explain it to me, and I just couldn't grasp it. So I just did my own little research, and I figured out what it was. And so basically, it's when either the cells that your donor gives you reject your host cells, and they start fighting them off, or your host cells reject your donor cells from your bone marrow transplant. And so it's like your body is like attacking itself, and it causes problems like a lot of times it causes rashes and mouth sores, and it can be fatal if you don't treat it, but usually it doesn't get that far out of hand if you're keeping up with your clinic visits. And it affects 30% to 70% of the people who have an allogenic transplant, which means that you got your marrow from a donor and it's not from a sibling, and it has to be matched. But if you have a mismatched donor, then you're most likely going to get chronic GVHD or acute GVHD because your T cells don't match up. The next thing I researched was understanding a patient, and this is one of the first things I researched when I started last year, because you really need to be able to understand what they're going through, because I haven't had cancer yet, and a lot of the doctors that treat them haven't had cancer, so we don't have firsthand experience of what it's like to go through all the chemotherapy and treatment. But you need to be able to explain to them you have an idea of what they're going through because of the patients you treat, and that they can open up to you and they can explain their problems, because that's the only way that they're going to get better. And this article talked a lot about how people weren't educated on cancer, and it sparked some of my ideas for my original work last year. I made a chart of all the pediatric cancers and explain their symptoms and what to look for and the treatments and stuff. And then it talked about how it takes a toll on their everyday life, and they think no one understands it. But as a doctor, you need to be the one that says, I can kind of get what you're going through, and it's okay. So my current research is so the first thing I researched was bone marrow transplants, because last year I researched more about the basic stuff, and this year I wanted to dig deeper into what my mentor does himself. And so basically he does bone marrow transplants and stem cell transplants. So I wanted to more understand them. So I learned that a bone marrow transplant is the addition of a donor's bone marrow to the recipient's, so you're the patient that has cancer, in hopes that the donor cells will engraft into the patients and function normally and help treat the cancer. And it's best to have an autologous one, because that means it's coming from either your cord, your umbilical cord, or a sibling, or your own if you have some that's functioning properly. But that doesn't happen that often because most people don't have their umbilical cord, and they don't, their cells aren't functioning properly, so you can't take out their own and use it. So they have to go the allogenic way, which means you're getting a healthy donor to donate their cells, and then those get put into the patient. And that's what starts to cause the problems, because either your host or your donor cells will reject each other, and then it starts causing problems. And then after the bone marrow transplant, because of the conditioning that they go through before they get it, a lot of chemotherapy and radiation to kill off a lot of their own, they're really weak, and they have to be isolated for an extended period of time so that they don't get any infections that can be fatal. So this is gives you an idea of how it works. So either the patient or the donor will either get their stem cells taken out by blood, or their marrow taken out by a spinal tap, and then they go into a little petri dish, and then they separate out the stem cells but leave with antibodies, and then they bind, and then they kind of preserve them, and then when it's time for the patient to have their bone marrow transplant, they thaw them out, and then they put them in a bag, or however they're going to do it, through here or through here, and then they infuse the stem cells, and we wait to see if they graft. And so you really want their T cells to graft. That's the most important part. The next thing, since my study is over fatigue, my mentor sends me fatigue articles all the time, just to keep me up to date with what other people are doing with fatigue. And so basically the article talked about how it was poorly studied late effect, and that the reason it's so poorly studied is because it's relative. Everyone experiences fatigue so differently. Our fatigue is different than the fatigue they're going to have, and one patient might say they're fatigued, but they can do a lot more than another patient who says they're fatigued. So you can't really measure it and treat it, because there's no scale, there's no 1 to 10 scale, and it's just based, you can't measure it, you don't know how fatigued they are or not. They could be lying about it. but it's caused by a variety of reasons, but it's mainly caused by the chemotherapy and the radiation and just like how drained they are from that. And this is a pie chart that explains how many cancer patients have fatigue. So 32% have fatigue every day. And their fatigue isn't our fatigue where we're just tired and okay, I'm gonna go home and take a nap and now I'm rejuvenated and I can do what I want. It's like, I'm sitting on the couch and I'm too tired, I don't even wanna pick up the remote, or I'm too tired, I don't even wanna get up to go to the bathroom. And it's like debilitating, like they cannot do anything, like they're so tired and drained. So that's the kind of fatigue that this is describing. And so then it shows on most days 21%. And then over here, even though it says hardly ever 20% have fatigue, 53% say they have fatigue often, like if you combine every day and on most days. So that outweighs the people who say they hardly ever. So it's clearly impacting a lot of patients and something needs to be done about it. So the next thing is Glanzmann's thrombocythemia. And it doesn't really have anything to do with like my clinical trial or stuff, but my mentor said like it's super rare. There's only been 300 studied cases, like, and there could have been more, but like before we started studying things like this and identifying, there's only been 300. And so they're rare and they're found in the Middle East. And we actually have a patient at Children's that's from the Middle East that came with this. And and I was like, I didn't understand what it was when he was talking about it. And he kind of explained it to me and sent me an article. And it's different, and it's mostly found in the Middle East, France, and India because it's usually children out of consanguinity, which means like intermarriage type. So since it's like an autosomal recessive, like they have a higher chance of getting that recessive gene because they're from the same like kin or like family, you know? So that's why it's more predominant in these countries. But basically what it is they lack platelet aggregation, which is the protein that helps them clot. And they start bleeding by like excessive bleeding by 1, and it's usually like in the mouth, like gingivitis type, but it's not like calm gingivitis like what we would experience. It's like heavy bleeding that doesn't just stop on its own. And there's no curative treatment for sure. They've had 3 that have been treated successfully with stem cell transplant or bone marrow transplant. So that's why the person's here to get that. And it's risky because of how like sick they are from the disease, that they can't cope with like the conditioning beforehand and the new cells after. So that's what causes it to be like so risky and like fatal when they get one. And this is just like the picture. Okay, here we go. So right here is a cell, and they're usually lacking the glycoprotein 2B or 3A. This is where they should clot, and they lack it, so it never actually clots to here, and they just keep bleeding. This is kind of like a recap of what I just said. So yeah. The next thing I researched was thalassemia major, and it's a blood disorder. And I researched it because for my original work, I was planning on researching not cancers and how they're treated with bone marrow transplant or stem cell transplant, but I don't know if I'm doing that anymore. So basically this is a disease where their red blood cells lack the protein to carry oxygen, so oxygen doesn't get to their tissues and they can't function as well. And it's a lifelong disease with no cure, so that's problematic. But some have been treated and like successfully, like 5-year survival rate afterwards with a bone marrow transplant. But it's extremely risky, like the Glanzmann's, because of the state that they are in from the disease they have. And it's best if it's done with a sibling because the cells match better. And here's a little picture of how it normally should function. Like this is your red blood cell, and it gets the oxygen, and then it passes it on, and the oxygen bonds, and this is what they don't have. The oxygen doesn't bond, and so they can't release it to the cells, the tissue cells. So then they don't get oxygen, and like throughout their body, and it causes a lot of problems. And then the last thing I researched was late effects. Again, just I like to keep up with what they're doing on late effects since my studies about late effects. So basically it's a medical condition that occurs after transplant, and it usually occurs about 1 year after transplant, but it can occur in between that time. Sometimes they start while they're getting their transplant and like post 100 days, but usually they don't. And they're like the fatigue, like still having fatigue after you're not being treated anymore, like they're still tired. And some of them are fatal, like they have heart defects from the treatment and organ failures from the treatment, and that's like a fatal late effect. And those are more studied because like they're fatal, but like fatigue isn't, because yeah, it's debilitating, but you can live through it. And those problems don't just stop there, like they start causing other problems. Like if you had a heart defect, like it's just going to keep spiraling downhill, like it's never going to get better unless it has treatment. And these are all like go back to just having your cancer treatment, like chemotherapy or radiation. And they can be long-term or they go away like after a while. So thank you for coming to my speech, and I can't wait to learn so much more about bone marrow transplants and fatigue through my mentor and my clinical trial, and I'm hoping to get some results so that I can share them with y'all at final presentation night. Thank you.